Welcome back to the fourth lecture of your Step 2 CK Surgery Review. It's Matt Kinney again, and in this two-part lecture, we will be reviewing the abdomen, which is where the majority of bread and butter general surgery pathology is found. You should expect a lot of questions about the acute abdomen on your exam, and will be expected to know the presenting symptoms, the diagnostic workup, and the treatment of choice for each of these common conditions, so all of the information in this lecture will be high yield on exam day. We will start by discussing the differential diagnosis of abdominal pain, and then we'll individually cover the commonly tested diseases, including mesenteric ischemia, esophageal disorders, and gastric perforation. When you encounter a question stem about a patient with abdominal complaints on your Step 2 CK exam, you should immediately begin developing a differential diagnosis in your head, and as you read the information presented, try to narrow that differential. Perhaps the easiest way to do this is to consider the location of the pain. While many conditions can cause diffuse abdominal pain, including constipation, gastroenteritis, and a bowel obstruction, if the patient describes a specific location to their pain, it makes diagnosis much easier. The most common cause of right upper quadrant pain is cholecystitis, which classically presents with right upper quadrant pain that radiates to the right shoulder due to referred pain from the inflamed organ coming into contact with the diaphragm. While cholecystitis is the most commonly tested cause of right upper quadrant pain, any gallbladder or liver pathology can induce pain in this location, including cholangitis, and a perforated duodenal ulcer can as well. The left upper quadrant houses the spleen, and splenic rupture after trauma is the classic cause of left upper quadrant pain, especially if the patient has a positive Kehr's sign, which is referred pain to the left shoulder, also due to diaphragm involvement. However, ischemic bowel disease, which we will discuss shortly, can also induce left upper quadrant pain. If the patient describes a mid-epigastric or centrally located abdominal pain, which radiates to the back, pancreatitis should be at the top of your differential. Conversely, if the pain remains localized to the epigastric area, and especially if the patient describes a burning type pain that is temporally associated with meals, you should assume peptic ulcer disease. And finally, while aortic dissection is often described as a tearing chest pain that radiates to the upper back between the scapulas, some patients may interpret the pain from a dissection as originating in the abdomen. With right lower quadrant pain, appendicitis is always at the top of the differential, especially in younger adults, because it is an extremely common condition. But in a female, you must also consider ovarian torsion, as well as the potential for an ectopic pregnancy. And finally, elderly patients with right lower quadrant pain may be suffering from diverticular disease in the cecum. Speaking of diverticulitis, it is the #1 cause of left lower quadrant pain on the exam, especially in older patients. The sigmoid colon is much more likely to be affected by diverticular disease than the cecum, so classically this is where diverticulitis pain occurs. Valvular twisting of the large bowel is also most common in the sigmoid colon, and will present with pain in the left lower quadrant as well. And again, since the ovaries are bilateral, torsion and ectopics can also be experienced as left lower quadrant pain. We will cover the bolded diseases in depth later in this lecture, but remembering the most common locations for each of these conditions is an easy way to quickly arrive at a diagnosis. To introduce the next topic, let's review a case. An elderly patient presents with acute onset abdominal pain. However, his exam is benign. Labs are drawn and reveal an elevated white count and lactic acid level. He is on Coumadin. What is the next step in management? Is it A, MRI of the abdomen, B, exploratory laparotomy, C, colonoscopy, D, oral antibiotics, or E, an EKG? When you see a patient with abdominal pain that is out of proportion to the findings on a physical exam, you should immediately think of acute mesenteric ischemia, a condition most frequently caused by emboli of cardiac origin, occluding the blood supply to the gut. In this case, you get the hint that the patient has atrial fibrillation based on their Coumadin medication, and thus are at risk for producing clots. There is a significant risk of bowel necrosis and perforation with acute mesenteric ischemia, and thus emergent surgery is required. While CT angiography would also be an appropriate step, It was not one of the available answer choices. An MRI takes too long to be utilized in the diagnosis of this or any emergent condition. Another important point to remember is that a colonoscopy should never be performed in a setting of bowel inflammation or necrosis due to the risk of bowel perforation. While antibiotic therapy may be helpful as a secondary precaution in the setting of a perforated bowel, it is not the definitive therapy for acute mesenteric ischemia. And finally, an EKG is not indicated here. We will further discuss acute mesenteric ischemia in a few slides, but first, let's review chronic mesenteric ischemia, a commonly tested condition that is seen in the elderly. The underlying cause of chronic mesenteric ischemia is atherosclerosis, which leads to plaque formation within the walls of the mesenteric arteries and subsequent narrowing of the arterial lumen. If severe enough, this narrowing can prevent sufficient perfusion of the gut, as seen in the image to the right. Note the graying areas of the bowel depicted by the arrows. These are regions of bowel ischemia. On your Step 2 CK exam, they will often help you arrive at a diagnosis of chronic mesenteric ischemia by mentioning that the patient has other sequelae of atherosclerotic disease, such as cardiac angina or peripheral vessel claudication. The classic symptom of chronic mesenteric ischemia is diffuse, crampy abdominal pain that occurs after meals. The pain can often be extremely severe and may be accompanied by nausea. The cause of this pain is synonymous with angina. In angina, exercise causes a requirement for more blood flow to the heart. In chronic mesenteric ischemia, it is the gut that has the increased oxygen requirement so that it can function to absorb nutrients from the meal, and when atherosclerosis prevents the necessary perfusion, it causes pain. The pain can be so severe that patients will actually stop eating in an effort to avoid it, leading to weight loss. The question stem may also mention bloody diarrhea because when the mucosal lining of the bowel does not receive adequate blood flow, it sloughs off, which is associated with GI bleeding. Note that like angina and claudication, this is a progressive condition that is dictated by the narrowing of the arteries, so symptoms may initially be mild, but if untreated can become severe and debilitating. Diagnosis of chronic mesenteric ischemia is made via CT, which is often the test of choice for abdominal complaints. A contrast CT is initially preferred because it is a quick and easy study and provides excellent sensitivity in identifying ischemic regions of the bowel, but the full workup of this condition requires a CT angiogram, which can not only confirm the diagnosis, but can also provide information about the location and severity of the arterial narrowing. The definitive treatment for chronic mesenteric ischemia requires vascular surgery and involves bypassing the diseased region of the artery in a procedure that is mechanistically similar to a cardiac bypass surgery. In preparation for this surgery, and for all elective surgeries that involve the bowel, the patient must not only be made MPO and be given IV fluids, but a bowel prep must also be initiated 24 hours before surgery to ensure that all of the enteric contents are expelled before the operation. Note that while surgery is the only way to correct the problem, nitrates may provide some relief to patients with mild symptoms by inducing vasodilation of the mesenteric vessels. As alluded to in the case we previously discussed, acute mesenteric ischemia is the result of an entirely different pathologic process and requires urgent diagnosis and treatment to preserve viability of the bowel. It occurs as a result of sudden onset, complete occlusion of one of the vessels supplying the bowel, most commonly the superior mesenteric artery. Greater than 50% of the time, this occlusion results from a thromboembolism, which forms in the left atrium of the heart and enters systemic circulation, becoming lodged in a mesenteric artery. Because of the geometry by which the arterial roots branch off of the aorta, the superior mesenteric artery is the most likely to be occluded, as can better be appreciated on the next slide. This diagram shows the abdominal vasculature as it branches off of the abdominal aorta. Note the appearance of the superior mesenteric artery, which on this slide is depicted by the blue arrow. If you follow the SMA to its origin on the aorta, you can appreciate the shallow angle by which it branches. This provides clots from the heart easy access into the SMA vessel lumen, causing downstream vessel occlusion as the clot passes into the narrower parts of the distal superior mesenteric artery. Another mechanism by which acute mesenteric ischemia can arise is the formation of an acute thrombus on an atherosclerotic plaque, leading to vessel occlusion in a process that is identical to the inciting event in an acute myocardial infarction. The resulting decrease in blood flow that occurs due to either of these causes leads to ischemia and infarct of the bowel, which occurs most commonly at the splenic and hepatic flexures of the large bowel, because these are watershed regions that already receive poor perfusion. The signs, symptoms, and laboratory findings of acute mesenteric ischemia are frequently tested on the Step 2 CK exam, so be sure to become very comfortable with the material on this slide, and it will turn into easy points on test day. As we talked about, the classic finding is acute onset abdominal pain that is severe, but is associated with a relatively benign abdominal exam, without evidence of pain to palpation, guarding, or rebound tenderness. The reason that these common abdominal symptoms are absent is that they arise secondary to inflammation within the abdomen. However, in early acute mesenteric ischemia, before the bowel has fully infarcted and perforated, there is no inflammatory process occurring, so no reason for the patient to develop peritoneal signs. Rather, the pain they are experiencing is synonymous to the pain associated with an acute myocardial infarction, that of tissue that is not receiving sufficient perfusion. Patients may also present with nausea and vomiting, and bloody diarrhea can be a delayed finding. Diagnostic indicators of acute mesenteric ischemia include an elevated white count and a lactic acidosis that results when the bowel must resort to anaerobic respiration because oxygen cannot be delivered distal to the clot, leading to the production of lactate. In the acute setting, an X-ray and CT should be ordered to confirm the diagnosis and may show air in the bowel wall, a finding also known as pneumatosis intestinalis, as well as localized swelling in the infarcted area and signs of bowel obstruction secondary to an ileus. While CT angiography of the bowel vasculature is the gold standard for making the diagnosis of acute mesenteric ischemia, it takes too much time to perform and thus should not be considered the test of choice for diagnosis in the acute setting. While not the ideal test to perform for diagnosing this condition in an emergent setting, this image reveals the appearance of acute mesenteric ischemia on a CT angiogram. The contrast-filled tubular structure is the superior mesenteric artery. On the image, you can see that the contrast is unable to pass beyond the point depicted by the red arrow, a result of the fact that the vessel is occluded at this point by a blood clot. As you can imagine, with no blood able to pass, and with little collateral circulation present on the image, it will not take long for the bowel tissue to die without an emergent intervention. When asked about the treatment for these patients, you should select an emergent laparotomy on your exam. While smaller vascular procedures, such as thrombectomy and embolectomy, can be performed in certain clinical situations, they are beyond the scope of your exam, and open surgery is the preferred option. The goal of an emergent XLAP with acute mesenteric ischemia is to open the abdomen and inspect the bowel for regions of necrosis. Any necrotic areas, or other areas clearly receiving poor perfusion, are at risk of perforation and must be resected. It should be noted that even with immediate intervention, this is still an extremely dangerous condition and mortality is high. Here is an intraoperative image of a patient with severe acute mesenteric ischemia leading to bowel necrosis. Note the regions of pink and brown bowel. The pink areas are regions of the bowel that are still receiving appropriate perfusion, likely via collateral circulation. Conversely, the prominent brown regions are not getting blood flow, and this is now dead tissue that, without surgical resection, is at serious risk of perforation, leading to spilling of bowel contents into the abdomen and the development of peritonitis. Thus, the general surgeons must resect these regions of necrotic bowel and later reanastomose the surviving regions. Let's now switch gears by tackling a case. A middle-aged woman, a known alcoholic, presents with chest pain after vomiting, but denies seeing blood in the vomitus. Palpation of the anterior chest wall reveals crepitus. What is the next step in the workup of this patient? Is it A, measure an ethanol level, B, chest x-ray, C, upper endoscopy, D, a barium esophagogram, or E, a gastrographin esophagogram? This patient is likely presenting with a full thickness tear of her esophagus, a condition that is also known as Boerhaave syndrome. There are few hints that should help you arrive at this conclusion, including the recent history of persistent vomiting and the absence of blood in the vomitus. But the most helpful finding here is the crepitus, which results from air entering the subcutaneous tissue and could only result from a full thickness esophageal tear. To evaluate Boerhaave syndrome, you must perform an esophagogram, which is a contrast-enhanced X-ray, but because the contrast will be able to escape the GI tract if a tear is present, you must use a water-soluble contrast agent like gastrographin, and not barium, which cannot be metabolized by the body. While an ethanol level would likely be positive in this patient, it is not helpful in diagnosing or treating this patient's emerging condition. A plain chest X-ray without contrast will not show you an esophageal tear, and performing a scoping procedure on this patient is absolutely and completely contraindicated because sticking a scope into a ruptured esophagus would likely increase the extent of the damage. The two most commonly tested injuries to the esophagus from the surgery material of the Step 2 CK exam are mucosal tears, also known as Mallory-Weiss tears, and Boerhaave syndrome. Being able to differentiate between the two is crucial to answering questions about these conditions, so Kaplan has prepared this slide to allow for a side-by-side comparison. A Mallory-Weiss tear is a superficial tear of the mucosa on the inside of the esophagus, and most commonly results from vomiting or retching, which leads to elevated pressures in the esophagus and the potential for tearing. Because vomiting is commonly associated with alcohol abuse, any condition for which vomiting is a predisposing factor is always associated with alcoholism, including Mallory-Weiss tears. While vomiting is also a major risk factor for esophageal perforation, the number one cause is actually complications from upper endoscopy, in which a scope penetrates the esophageal wall. The classic symptoms of a Mallory-Weiss tear are bloody vomit due to tearing of the superficial vessels in the esophagus, as well as pain with swallowing. Hematemesis may occur in rare cases of Boerhaave syndrome, but is not classically present. Instead, these patients usually complain of a severe anterior chest pain just behind the sternum that begins after an episode of vomiting. Because the inflamed esophagus contacts the left diaphragm, left shoulder pain may be present as well. And finally, a full thickness tear through the esophageal wall allows air from the GI tract to enter the subcutaneous space, which on exam will appear as a crackling or a crunching sound with palpation of the upper chest due to the presence of air in the subcu fat. If asked about the location within the esophagus of each of these injuries, Mallory-Weiss tears most frequently occur at the most distal aspect, the gastroesophageal junction. Esophageal perforations occur just proximal to the GE junction in the distal portion of the esophagus, and statistically is most frequently seen in the left posterior lateral aspect, which is unfortunate because it allows for the entry of esophageal contents into the mediastinal space. As discussed in the previous case, diagnosis of both of these conditions is made with an esophagogram that uses a water-soluble contrast agent called gastrographin. If the injury is a simple mucosal tear, then the contrast material will not be able to escape out of the esophagus, but if it is a full thickness tear, you will see leakage of the gastrographin through the esophageal wall defect. In terms of treatment, most Mallory-Weiss tears are relatively benign and can simply be monitored until the bleeding stops, and if absolutely necessary, the vessels can be cauterized. Complications are rare in this condition. Compare that with Boerhaave syndrome, which is an incredibly serious condition that requires emergency surgery to repair the defect. Despite early intervention, the mortality associated with this condition is about 25%. The dreaded complication of an esophageal perforation is acute mediastinitis that results from infection of the mediastinum secondary to the passage of esophageal contents through the tear into the mediastinal space. These patients will further complain of anterior chest pain and will also have signs and symptoms of a severe infection, including fever, chills, and an elevated white count. Mortality associated with acute mediastinitis is extremely high. With that dense slide out of the way, let's look at another case. An obese middle-aged man comes to the ED with complaints of weakness. He has been vomiting blood and also has blood in his stool, along with persistent mid-abdominal pain. He reports taking a PPI for a history of heartburn. Vitals show a decreased blood pressure and an elevated heart rate. What is the diagnosis in this patient? Is it A, gastric perforation, B, hemorrhagic ulcer, C, Boerhaave syndrome, D, diverticulosis, or E, acute mesenteric ischemia? This patient has peptic ulcer disease, as hinted at by the heartburn, obesity, and the fact that he is taking a PPI. There are two major complications of peptic ulcer disease: gastric perforation and hemorrhage. Hemorrhage occurs when an ulcer erodes into the gastroduodenal artery, causing a potentially life-threatening GI bleed. Along with reports of vomiting large amounts of blood and the abnormal vitals, you can also tell that this patient has a severe upper GI bleed because of the bright red blood in the stool, also called hematochezia. Perforation releases gastric contents into the abdominal cavity, leading to peritoneal signs, but not bleeding. Boerhaave syndrome classically doesn't include hematemesis and almost certainly wouldn't present with hematochezia. Diverticulosis may result in bright red blood per rectum, but bleeding is clinically insignificant and you would not have hematemesis. Lastly, acute mesenteric ischemia may cause minor bleeding, but not enough to cause gross hematochezia. Also, you would expect the patient to complain of severe abdominal pain. Gastric perforations occur almost exclusively in patients with a history of peptic ulcer disease. So if the test makers want you to be thinking along these lines, they will mention heartburn in the question stem or tell you that the patient is taking a PPI or an H2 blocker. In a healthy patient, the mucosal lining of the stomach provides a barrier against the destruction of the underlying tissue by the acidic gastric contents. However, in peptic ulcer disease, a combination of elevated production of gastric acid and damage to this mucosal lining allows for the formation of ulcers, which can be appreciated in the image to the right as the regions of mucosal discoloration depicted by the red arrows. Many risk factors predispose to peptic ulcer disease and subsequent gastric perforation, starting with infection with Helicobacter pylori, a gram-negative bacteria that colonizes the lining of the stomach and leads to mucosal damage. The path image to the right depicts these bacteria invading the stomach mucosa. Nonsteroidal anti-inflammatory drugs block prostaglandin production, a key component in the synthesis of the stomach mucosa. Ulcers can also arise as a result of burns due to decreased intravenous volume and subsequent sloughing of the stomach mucosa, as well as trauma, especially trauma to the head. Certain cancers predispose to peptic ulcer disease as well, especially gastrinomas, which secrete gastrin and lead to increased production of stomach acid. And finally, while alcohol and tobacco do not actually cause stomach ulcer formation, they do prevent normal healing of ulcers that are already present and thus predisposed to perforation as well. As discussed in the case, there are two concerning complications of peptic ulcer disease that appear over and over on the Step 2 CK exam. The first is gastric perforation, in which an ulcer becomes so deep that the stomach acid is actually capable of eroding all the way through the outer layers of the stomach wall. This allows the stomach contents, such as partially digested food, bacteria, and acid, into the abdominal cavity, which leads to subsequent inflammation of peritoneal structures. Peritonitis is a common complication of gastric perforation, as you might expect, and can result from a perforation at any location in the stomach. However, perforation of a posterior gastric ulcer can allow gastric acid to reach the pancreas, where it will subsequently destroy pancreatic cells and release pancreatic enzymes such as amylase and lipase into the peritoneal cavity. The second complication of advanced peptic ulcer disease occurs when an ulcer erodes into an artery, most specifically the gastroduodenal artery. This is a more common complication than gastric perforation, and due to the posterior location of the gastroduodenal artery, this condition is most frequently seen with posterior ulcers. To stop a major arterial bleed such as this, an endoscope must be passed into the stomach to evaluate the extent of the damage and cauterize the vessel. As we've already talked about the presentation of gastric hemorrhage in the case above, let's now focus on the signs and symptoms of a gastric perforation. Initially, patients will complain of an acute onset pain in the epigastric region that is considerably more severe than their usual heartburn symptoms. Furthermore, this pain may radiate outside of the abdomen, often to the right shoulder due to referred pain from the phrenic nerve. The pain will then progressively increase as more tissue becomes inflamed. Soon after the rupture, a chemical peritonitis will develop, so these patients may present with the classic signs of peritonitis, including rigidity of the abdominal musculature, guarding, and the telltale sign of rebound tenderness, or pain that is worse with the release of abdominal pressure. The initial diagnostic test for gastric perforation is a plain film of the chest looking for the presence of free air under the diaphragm. Note the two arrows seen on the X-ray to the right. The arrow to our right, the patient's left, is a normal finding, the air bubble in the stomach. But the other arrow depicts air under the right diaphragm, air that shouldn't be present in a normal abdominal cavity. In this patient, who has experienced a gastric rupture, air from the GI tract escapes into the peritoneal cavity and localizes under the diaphragm when a patient is standing upright. Note that free air purely signifies a rupture somewhere within the intra-abdominal GI tract, anywhere from the stomach to the large bowel, so you must correlate the finding of free air under the diaphragm with the patient's presenting symptoms to better assess the actual location of the rupture. And while X-ray is the best initial test to evaluate this condition, an abdominal CT is the gold standard for diagnosing a gastric perforation. The treatment algorithm for a gastric perforation is very specific, and the Step 2 CK test makers will likely ask at least one question about it to ensure that you not only know the steps involved, but also the rationale behind each step. The first thing you must do is prevent the patient from eating, which would increase the contents of the stomach and allow more escape into the peritoneal cavity. Along these same lines, a nasogastric tube must be inserted and placed to suction to ensure that the stomach is fully emptied. Secondarily, this will also suction out any newly formed acid, preventing it from escaping into the abdominal cavity and worsening the inflammation. These patients should also be given broad-spectrum antibiotics to combat peritoneal infection that may result from bacteria being granted access to the previously sterile peritoneal cavity. They must also be prepped for surgery by giving them IV fluids. And finally, an exploratory laparotomy must be performed not only to repair the defect in the stomach wall, but also to wash out the abdomen in an effort to further decrease the risk of infection. Alright, that's it for part 1 of the surgical abdomen lecture. Please continue on to part 2.